Okay, so today I'm going to start with, until the break, just a quick run through with the endocrine emergencies, and then we have 2 lectures. You have the 100 top drugs, a few of those that Jesse's going to get up and talk about and review with us. And then there's a test, and you should also have a series of rhythm strips with, or actually EKGs. There should be 6 of them with questions. So you should have all been, they didn't get those?
No, sir.
Rich.
Trying not to load them up to see what I get back from the drug review. Next month.
That's just Jesse. I mean,
Next month I need a double hit.
you guys got to catch up. Got to catch up. All right, so we're going to really spend most of the time with the kind of endocrine things you can deal with, because unfortunately most of them you can't. And a lot of them you're not going to recognize clinically because they look like everything else. So the same basic stuff that we always do with everything, ABCs, pre-hospital management that we can do, you're going to continue to do. You're not going to have success recognizing some of the other issues, only because you can't do any kind of studies that delineate if it's related to an infectious process, a hormone issue. You do have to rely on your history extensively and the meds that the patient has. So when Jesse sees somebody's taking Cytomel, he knows what that is, and he's going to take care to treat that patient. Somebody read something. Okay, so we're going to talk about this endocrine system. You know, I think the key here is that first statement. You see a broad range of signs and symptoms, so there's nothing really hard and fast with it other than the diabetes that we'll see. The rest of it, you don't test their thyroid gland. You might recognize thyroid storm in a patient who's got a swollen neck, and it's tender to touch, and they're kind of hyper and tachycardic and may have a fever. So you might recognize that. You certainly can't test their thyroid, but it is something that clinically you might see. So we know that the endocrine system is a network of glands, as they state here. It is sort of a symphony, as one of my instructors said to me many years ago, of your body's physiologic status, meaning that all of these glands work together. You know, I treat a lot of hormone dysfunction, mostly testosterone, some thyroid and estrogen, progesterone issues, but they are not isolated situations, okay? It's important for you to understand that. The hormones all function in conjunction with each other. So if you have low T and you come in and your thyroid stimulating hormone, or TSH, is high, it can be because your testosterone is so low. So you need to fix things and watch the adjustments that the body makes and changes in your metabolism. You don't just throw drugs at it and think that that's all you need to do. You may have seen this before, exocrine and endocrine glands. I don't think that we really speak of this at our level. It's sort of more basic in terms of medicine, so I wouldn't worry about that. This picture, though, is something that you should try to keep in mind, mainly because if you look at where the pancreas is, you can see that patients with abdominal pain can have that pain referred to their epigastrium, because the pancreas sits behind that, behind the stomach, right underneath the diaphragm. So when you get a complaint of abdominal pain, one of the things you want to think of in a diabetic is, does this patient have pancreatitis, or do they have a phlegmon, which is like a huge pancreatic cyst filled with pancreatic enzymes? Because that is something that in a diabetic, well, in anybody, but specifically a diabetic, can be a major problem. Phlegmons, sometimes they have to drain them. Sometimes they'll go away if it's infectious. Antibiotics, it depends on the cause. Many years ago, I had a woman in ICU in New Jersey when I was doing family practice as well. And she came in with belly pain, big obese diabetic woman, and she had a massive phlegmon that eventually needed to be drained and then resected because it wouldn't stay away. She survived. She should have died, but she survived. Most of the time when it's that big, they don't do well. So just look at where the adrenal glands are too, because with what you deal with in your daily activity, you're under adrenal stress all the time. So your cortisol levels initially go up and eventually you burn them out and they drop. And you see they sit on top of the kidney. So those are the two important ones that we deal with. Thyroid, everybody knows where that is. Pituitary in the brain, testes, some of you know where that is. Ovaries.
I know where those are at. I got two.
Yeah. I heard that. You've heard these terms, agonist, antagonist. One triggers a response, one blocks the response. So it's pretty basic. Again, I'm not going to spend time with that kind of stuff. There are feedback systems to maintain your optimal physiologic status in your body. Your regulation, as you see, is really dependent upon what stresses your body's under. Now, when this shows you this little chart on the left, this is what the adrenal gland responds to when you secrete cortisol. Cortisol will suppress other hormones, in particular testosterone, estrogen. It can elevate glucose. So it does things almost as a master gland would do, although it's not considered the master gland in the body. Basic definition of disease. You all should have already seen these slides. Okay, so one of the most important feedback mechanisms, especially with testosterone, whoa, this is huge. It's called the HPT axis, hypothalamic pituitary testicular axis, for testosterone regulation. And it's the same basic axis for all of them, although it would just be the hypothalamic pituitary axis, which controls the target organ or gland. In this case, testes, it can be pancreas, it can be adrenal glands, but it comes from the same place in the brain. It determines when that gland functions, what it secretes and when, how much it secretes, based upon the need of the body. As you see, it does hook the endocrine and nervous systems together because its hormones were reflected in neural changes in the body, chemical changes in the body, and you can get some emotional changes. We don't really do much with the pineal gland. As we age, melatonin decreases. Melatonin is needed for growth hormone production and release. That's why as we age, our growth hormone drops. You can take extra melatonin and it will elevate your growth hormone over time, but it takes a lot of it. So the 2 to 5 milligrams, most of those pills are that you see that we use for sleep induction with melatonin isn't really enough to do much with growth hormone. It takes almost 20 milligrams of melatonin to elevate your growth hormone. And you can't just start taking 20 milligrams, you'll get sick. You'll have a raging headache. Melatonin is made at night during our sleep cycle. Working shift work, you of course aren't going to have normal melatonin production. Pituitary gland is one of the master glands and controls all the others. I don't know if you can see that chart, but you see that it secretes growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, luteinizing hormone, follicle stimulating hormone, prolactin, antidiuretic hormone, and oxytocin. So there's some major hormones in your body. What is antidiuretic hormone? What does that mean to you? Nothing. Jesse. Nobody knows? Antidiuretic hormone. What do you think it does? What? All right, so it's going to control fluid balance, okay? Somehow it controls fluid balance. And where does that mean that it works? Okay, so it has to do something in the kidneys controlling fluid balance. What's SIADH? Syndrome of inappropriate secretion of antidiuretic hormone. Another term for it, or I should say it's similar, diabetes insipidus. Okay, not something you commonly see. What's ACE and ARB mean? What do you think it means? You've all heard of ACE inhibitors, haven't you? ARB blockers. What does that have to do with this? How do they work? That's why you need to know the drugs. Lisinopril. What's lisinopril? What's losartan? You tell me. I gave you the drug, losartan. What's losartan used for? Guys, got to know these drugs. How could you go out there and treat patients? These are the most common things you see in the street. Lisinopril, Vasotec, common hypertensive meds. They're ACE inhibitors. Losartan, Cozar is a trade name, a little bit older drug. There are blockers. They work differently in the kidney. Same general mechanism. What's a complication of an ACE inhibitor? What's a life-threatening complication of an ACE inhibitor? From what? Angioedema. How many times you got a call for somebody that said they're having trouble swallowing and their lips are swollen? And what's one of the questions you ask them? What meds do you take? And if you see a drug called lisinopril, what does that tell you? They're having angioedema to an ACE inhibitor. What do? You better make sure that airway's okay, because we tube these people before they close off. And you won't be able to get a tube through them once they swell shut, believe me. Rich, I expect next time they will know the difference between an ACE inhibitor and an ARB blocker. Make up a 10-question test about the differences between them. And when we start next month, that's the first thing they do. They get the test the morning of the lecture. All right, so this is just generally shows you how the hypothalamus and the pituitary affect our different glands. You see that it will secrete the hormones to the ovaries, to the testes, to the adrenal glands, the thyroid gland, and it shows you the hormones. So luteinizing and follicle stimulating hormones, something I measure in both men and women because it drives the testes to secrete testosterone, ovaries, estrogen, progesterone. ACTH, we do something called an ACTH stimulation test for adrenal fatigue. Thyroid stimulating hormone for the thyroid gland, we measure that in the blood. Growth hormone, we measure that in the blood. MSH, we don't measure that. Some melanocytes in the skin related to melatonin. Prolactin, we measure. It's a pituitary hormone, one of the main hormones that are secreted. High prolactin levels can be from tumors in the pituitary gland. There's other things that can do it. That's the main one. antidiuretic hormone in the kidney, and oxytocin, mostly for contraction of the uterus. Now, we talked about a little bit of a thyroid issue with thyroid toxicosis, thyroid storm, something that clinically has some findings, although, again, as I said before, a lot of these are fairly nonspecific. So you might have an idea what's going on. There's nothing you're going to do about it in the field other than the basic ABCs that you always do. I'm not going to get into the metabolism of the thyroid gland. It's simple, but it's simple as it is, it's also complex. And we measure something called T4 and T3 in the thyroid gland. We measure something else called reverse T3. We measure something called TPO antibodies. None of that is something you're going to identify in the field. Thymus gland doesn't operate much in adults, but it is where you had your T cells and made and your lymphocytes for fighting infections, viral and bacterial. Parathyroid glands are above the thyroid. Some patients have issues with their calcium and PTH, and they require their parathyroid gland to be removed. Again, clinically, they're not going to present to you as anything life-threatening. They're not going to call you because the parathyroid gland's dysfunctional. Adrenal glands, you all have this problem. You all have adrenal fatigue from the type of work you do and from the shift work. Over time, your cortisol levels get too low and you're not able to function. You lose your focus, you lose your sharpness, your alertness, you lose your strength. Your sex drive goes away. You become pretty complacent and not very alert. You can get sick because your immune system is depressed from it. So, adrenal glands also secrete, besides cortisol, which is the main thing they secrete that we measure, also secretes aldosterone, epinephrine, norepinephrine, and the different classes, okay? Cortisol is a glucocorticoid, it's a steroid, but it's not a sex steroid. Aldosterone is a mineral corticoid, and you can see the functions. And then epi and norepi are catecholamines, that work specifically on the sympathetic nervous system. So if you think about this, think about what you do for a living and about the hours of boredom interspersed with hours of sheer terror or minutes of sheer terror. You can see how your adrenal glands are going up and down and you're always on the edge, and that tones go off and your heart starts racing. You may get a little sweaty, you get a little short of breath, and you go run out to the truck, you get in there, and you wonder, okay, what the heck do I have here now? Is it a fire? Is it an emergency? And do we need a fire truck or an ambulance? So we're getting into the pancreas, which is where we're going to spend most of our time. You have different kinds of cells in the pancreas, and we're going to talk about diabetes and specifically beta cell dysfunction. Alpha cells secrete glucagon. Do we use glucagon? We use glucagon. The answer is yes. What do we use it for? Right, low blood sugar. We give it to patients with low blood sugar to elevate. EMS carries glucagon. What else is glucagon used for? Anybody been scoped? Had endoscopy done? They gave you glucagon. Why did they do that? What? Nope, has nothing to do with the liver. In a way, it's a smooth muscle relaxer. Tried it for kidney stones, didn't work. It does work for GI issues. We use it in esophageal foreign bodies, see if we can relax the spasm of the esophagus to let the object drop into the stomach and get passed through normally. Sometimes it works. I've found that frequently it will work if you give a narcotic and some Valium at the same time. Does not work by itself, but the GI people use it all the time before they scope you. You're just out and you don't realize you're getting glucagon to relax your sphincter so they can pass the scope up easier and relax the bowel. So you have alpha cells, beta cells, and delta cells. Most of what we deal with is in the beta cells. These come out of the islets of Langerhans, which secrete the hormones, glucagon, insulin, and somatostatin. Somatostatin is a substitute for growth hormone. Now, if you look at the table on the side, the hormones of the pancreas, those are the three we talked about: insulin, glucagon, and somatostatin. And read the functions, because this is how physiologically you treat patients who have either high or low glucose levels. Now, there's certain things that happen over time with diabetes, and you become insensitive to the insulin. Usually these are individuals who are overweight, may have metabolic syndrome. The insulin does not help them transport the glucose across cell membranes, so they get fatter and fatter. There's only 2 diabetic medications that don't cause obesity. Only 2. Anybody know what they are? Byetta is an injectable type of insulin. It is not insulin. And Invokana is an oral agent. So when your fat Aunt Rose wants to know why she's getting fatter on insulin, you're going to tell her because it causes obesity. Maybe you should ask your doctor about Byetta insulin or Invokana. All the oral agents other than Invokana, and there's one other new one that just came out, cause obesity. Why do they do that? Why do these not cause obesity? Look at the first statement about insulin. What does it say? Problem is, we reabsorb our sugar in our kidneys across the cell membrane and put it back into our system with all the other agents. These agents don't allow that to happen. So you excrete the glucose. What is that called in a diabetic who pees a lot? Okay, why do they have it? All right, they have it because of what? A high glucose, and they're pissing out sugar because their glucose load is so high. So, in a way, this causes polyuria. It does it because it prevents the kidneys from reabsorbing glucose, which long-term lowers your hemoglobin A1C, lowers your glucose immediately in terms of your environment. The problem with it is, and think about this, you have an obese woman who's peeing out sweet urine. What does sweetness cause in people? Very common skin condition. What's it called? No. It's a rash, kind of rash. No. No, candida, yeast. What likes sweetness? Yeast. You can get it on the tongue. Fat people get it in here and their groin. What happens with a woman who takes Invokana, and many times they can't use these agents, and I've tried it on overweight women and they can't take it, they get yeast infections, vaginal yeast infections. They cannot control them because they're eliminating so much sugar that that yeast likes that sweetness, likes to grow in those folds, and that's what it does. And you can't get it under control. Years ago, they called it the beastie yeasties. Beastie yeasties, because it would itch and drive you crazy. Okay, so let's continue in this vein. Not going to talk about this too much because you're not going to deal with that. We're going to get back to diabetes. So let's talk about the history and physical. Now, I mentioned polyuria. So these are the 3 hallmarks of, and this isn't just undiagnosed, this is poorly controlled. as well, okay? So polyphagia, polyuria, and polydipsia. So what does that mean? Polyphagia is what? You want to eat all the time. Polydipsia is what? You're always thirsty. Polyuria is you pee a lot. And this makes sense if you think about in a new onset diabetic or somebody that's not controlled and their sugars are high, that's what they're going to do. The problem is that in a patient who's not controlled, who always runs 240 blood sugars, when you turn them into a blood sugar or bring them down to a blood sugar of 140, they're going to have symptoms of hunger. They're going to have dizziness and headache, and they're going to feel fatigued because their body's not used to a sugar of 140. It wants that sugar at 240 because it likes that energy jolt it gets with all that sugar being metabolized and transported in and out of cells and reabsorbed again. So even in a patient who normally runs 200 blood sugars, when you bring them down to a normal range, they're going to want to eat and drink, and they're going to have symptoms of hypoglycemia, but in fact, their sugars are out of control. They may not have all these symptoms. You really have to ask them, because to them it may be normal. They may not think of it. So we know that diabetes is a dysfunction of the islet of Langerhans cells in the pancreas. We know that, and you will know today, that we have not, in all the years of diabetic research, 60 or 70 now, been able to change the ultimate outcome of diabetes in patients. We have not been able to affect the function of the beta cells, per se, of the pancreas. Insulin does not change the beta cells. We're just giving the body something that it doesn't make in type 1 or doesn't have enough of in type 2, or we stimulate type 2 diabetics to secrete more insulin. But we have not changed the outcome. And what do I mean? On average, at 17 years of having diabetes, whether it's well controlled or not well controlled, you will develop all the complications of diabetics. You'll develop the peripheral vascular disease, the cardiac disease, the microangiopathy, the retinal angiopathy, the changes that occur from the vessels being damaged, kidney failure. It'll all happen to you. We have not been able to change that because we can't change the effect of the beta cell. We have not been able to fix that. Now, there was some hope with some diabetics with weight loss that sometimes they didn't require any more medicine. Gastric bypass showed in some patients that they had diabetics when they were 400 pounds or diabetes when they were 400 pounds, and with the gastric bypass and they went down to 180 or 200 pounds, they no longer required any medication for diabetes. But that's not universal. And we know that medications for diabetes causes obesity, which of course causes metabolic syndrome and makes you insensitive to the insulin and the medication that you take. So what do we usually deal with as an endocrine emergency? Well, again, remember, we really are talking about diabetes, so hyper and hypoglycemia, okay? There may be a compromise of the ABCs. We'll see in DKA and hyperosmolar non-ketotic diabetics. There may be some mental status changes because of the fluid balance and the sugar shifts that occur. Really, the fluid balance gets disrupted because of the sugar shifts. So fluid balance is an issue. There may be deteriorating mental status, and your vital signs may be abnormal, as well as your blood sugar levels. So we already know that with diabetes, you have a problem metabolizing sugar. We already know that. Is it because you have no insulin as in a type 1 diabetic, or is it because you have insulin but your pancreas isn't releasing it, and you need to stimulate that release, which is what the oral agents do? We know you need insulin for the transport of that glucose into the cells and the metabolism of carbs. This is just a little picture that shows glucose, pancreas, and the effect of insulin on it. Jesse will do his lecture on diabetes next month, and he'll go through this in detail.
You said the type 2, the pancreas doesn't secrete the insulin?
No, type 2, it has insulin, doesn't secrete enough of it, so the meds are used to stimulate the secretion. Now,